Hello, students. My name is Dr. Astha Jain. I'm a consultant pediatrician neonatologist. Today, we will be discussing a very important topic and a very commonly prevalent condition in children, iron deficiency anemia treatment in children. Now, it is a very simple topic. Most of you already know it. Let's quickly just revise it. What is iron deficiency anemia? Iron deficiency anemia, or IDA in pediatrics, it's a common condition where a child's body doesn't have enough iron to produce hemoglobin. You know, hemoglobin, which is formed of heme and globin chains, requires iron to be produced, right? So your heme requires iron. And when the body does not have enough iron, hemoglobin produced is less, and hence the oxygen carrying capacity of RBCs is reduced because this hemoglobin is required for oxygen to be carried by the RBCs. Now, iron deficiency anemia, it is a microcytic hypochromic type of anemia caused by insufficient iron stores. What is microcytic? Microcytic is small RBCs. Okay, micro. Macrocytic, cytic means cell. So a small cell, hypochromic. Hypochromic is pale colored or less colored. Hyperchromic is more color, right? Hyper would be less colored. So basically, what do you see? This is basically a microscopic picture of what do you see under the microscope when you put in a slide of, or the blood smear of a child who has iron deficiency anemia. You will see small RBCs which are light colored. This is caused by insufficient iron, and this is the most common nutritional deficiency in children. So, amongst all the deficiencies that occur, iron deficiency is the most common, and the most common presentation of iron deficiency is iron deficiency anemia. Now, what are the causes? Very simple. Naturally, if the intake per se is low, if you're taking in less iron, that means in children who are malabsorbed, who are malnourished, who are eating less, they are going to have less iron stores because their dietary intake per se is low. Second is poor iron absorption. When there are malabsorption syndromes, when the absorption of the iron in the body is less, right? So they're taking in enough iron, but the absorption has become a problem. Which part of the intestine does iron get absorbed in? In the duodenum. So when there is a problem with iron absorption, then there may be iron deficiency anemia. Rapid growth phases. So now there are phases in childhood, or rather even infancy, where you would see that the iron stores dip. Even though the child is taking enough iron and it is getting absorbed properly, there are sometimes physiological spurts where there is a deficiency of iron in the body causing iron deficiency anemia. And then there are when there is chronic blood loss, like in parasitic infections. You know, there are parasitic infections like entamoeba, histolytica, and all of that, where you lose blood constantly. And hence, you can have microcytic hypochromic anemia. What are the clinical features? They're very simple. First is pallor. The child will appear pale. Where will you look for pallor? You always look in the palpebral conjunctiva. Okay, in the palpebral conjunctiva, that is when you pull your lower eyelid down. Okay, and also in children, in smaller children specifically, you can check in the palms of the hand. Okay, in the palms of the hand. Fatigue and irritability. B- Because the oxygen carrying capacity has come down, right? The cells are not getting enough oxygen, and hence there is fatigue. Then they are very irritable also. They tend to get more irritable because the oxygen per se that is reaching is lesser. Poor concentration. Yes, another important symptom. Concentration is poor. Pica, eating non-food items. So they have a habit of eating non-food items like your soil, your paint of the walls. So this is typically seen in children with iron deficiency anemia. Now, glossitis and koilonychia. What is glossitis? Glossitis is inflammation of the tongue. Glossa is your tongue, and itis. So you will see it appears slightly inflamed red. There is glossitis, and not as uh, significant as you see in vitamin B12 deficiency, but some amount of glossitis may be there. And koilonychia, that is the shape of the nails, they become koilonychia, that is depressed from the center. A crater gets formed, and you'll see koilonychia. One another important feature which is seen sometimes in children, specifically, is pagophagia. Do you know what pagophagia is? They tend to eat ice cubes. Okay, so this is also seen in iron deficiency anemia. And another one is restless leg syndrome. So since they're always irritable, there is this, you see a movement of the leg constantly. Restless leg syndrome is also seen. So clinical features of iron deficiency anemia are important. Please note them down. How will you diagnose? How will you make out that this is iron deficiency anemia? Just a simple plain CBC is enough. So if a child is pale, after a child has come to you, you've seen that the child appears pale, you send in for a CBC. What do you see on CBC? You see that the hemoglobin for that particular child is in that age range, and for that gender is less. So in children, you cannot define iron deficiency anemia as like how you do in medicine or in adults. Like for males, it has to be 15 or 14. In females, it has to be more than 13. This is how they define it in adults. For children, for various age groups, the hemoglobin cutoffs is different, and it also differs in males and females. So you should know that cutoff, and only then you can call it anemia. So hemoglobin for that particular age and also that gender. MCV, the mean corpuscular volume is low, and the mean corpuscular hematocrit is low. So MCH and MCV both are low because you're seeing microcytic, small, and hypochromic anemia. What does your peripheral smear show? It shows microcytic hypochromic RBCs, serum ferritin levels, which is the iron stores of the body. Ferritin levels, right? They go down. Serum iron, if you send for, that is also less. But the total iron binding capacity in turn, as a compensatory mechanism, the total TIBC, that is raised because the body realizes that the iron stores of the body has come down. So the TIBC per se increases. Total iron binding capacity increases. This is a very important slide, and this can be asked also. So please note this down. Oral iron therapy, when you're starting iron orally, what do you give? Iron is available in oral formulations with other compounds. You do not plainly, iron is not available. It is always available in formulations. Most commonly given are ferrous gluconate. So you can remember it as SGF, ferrous sulfate, gluconate, fumarate. And what is the dose? 3 to 6 mg per kg per day in 2 or 3 divided doses. In 2 divided doses is fine. Otherwise, for some children, we also give OD. See, because iron should not be given along with calcium because it causes disturbance in absorption. Then it cannot be given with certain foods. Then it may cause constipation. The child may not like the taste. So if you give it twice or thrice, the compliance becomes less. So an OD dose is ideally preferred. And the doses being 3 to 6 mg per kg per day as per the hemoglobin of the child. If you want to start just prophylactically, you can start at a 4 mg per kg per day. But if you're giving to treat a child, then a 6 mg per kg per day would be decent. And you get syrups very readily. You even get drops for newborns. Preferably given between meals with vitamin C for better absorption. So between the meals, after the child has already taken a meal, give it a rest for around 2 hours and then give iron. Duration 3 months after normalization of hemoglobin. So you ideally give it for 3 months and then you check hemoglobin if it has raised. Parenteral iron. Where is IV iron indicated? So most of the cases in your OPD and all, you will give oral iron. But IV iron is indicated if oral iron is not tolerated or ineffective. So even after giving multiple courses of oral iron, if the hemoglobin is still low, what do you go for? You give IV iron. It is indicated if there is severe malabsorption. If the iron that you give, if it is malabsorbed, if it is not getting absorbed properly by the body, then you give parenteral iron. It has to be given in an IV formulation. And what are the preparations? Iron sucrose, ferric carboxymaltose. So these are the IV formulations that are available. Monitor for anaphylaxis. So when you're giving any IV medication, you will have to check for any allergic reactions or any anaphylaxis, so that you have to carefully monitor for. Follow up and prevention. Recheck hemoglobin after 4 weeks of starting iron. Continue treatment for at least 3 months after HB normalization. Even after the HB is normalized, it is recommended that you continue treatment for 3 more months. dietary counseling. So iron therapy and all is fine, but you must counsel them to take things that are rich in iron, like green leafy vegetables, jaggery, iron fortified foods, anything that is iron fortified salt that can be given. Jaggery, the one that you get in your local markets, the dark jaggery that you get, that is very rich in iron. Ragi is rich in iron. Green leafy vegetables, non-vegetarian foods, they are rich in iron. So parents must be counseled thoroughly. Also, breast milk is not very supremely rich in iron. So these children, so most children tend to suffer from iron deficiency anemia. And secondly, our mothers, Indian women suffer from a lot of IDA, and hence their iron stores are low, and the children also suffer from IDA. So supplementation becomes increasingly required. Why is deworming done every 6 months? Because a lot of parasitic infections, as we've spoken earlier, can cause iron deficiency anemia, like enteromoeba histolytica. So you deworm a child, you deworm with albendazole every 6 months, as per your national guidelines. Thank you.